Good afternoon, everybody. This is clearly the place to be on Tuesday afternoon. We're going to talk about the role of private providers in expanding affordable, quality maternal health care. Excellencies, Honorable Minister, distinguished colleagues and guests, really it's wonderful to welcome you here. I'm Jill Sheffield, President of Women Deliver, and on behalf of Women Deliver, it's a really unique and wonderful opportunity to say how great it is to work with the partners who are in the room today, and especially Family Care International and Merck. The role of private providers in expanding access to affordable, quality maternal health care is on our minds, front and center, where it should be, of course. As we gather here in New York for the United Nations General Assembly and assorted other meetings, we have to keep in mind that the health of girls and women is truly at the heart of development. Women drive economic development. They contribute to growth. In fact, they make everybody's work just much more productive. So protecting their health is the right thing to do, and it's the smart thing to do, because when women survive, families and nations thrive. The good news is that maternal mortality is finally on the decline. But even one maternal death, one preventable maternal death, is one too many, and we do know how to prevent the large number of them. Each of us in this room has a very specific role to play in delivering on MDG 5, saving the lives of girls and women and improving their health. We're going to hear from our wonderful partners and the speakers about how they've contributed to progress on this issue. We really need to prioritize innovative solutions for girls and women. This includes supporting private providers and health businesses where they go for services. And by working together as global leaders from civil society, from governments, from UN agencies, NGOs, the private sector, we can, we do, and we will make a difference. So we're looking to 2015 and frankly beyond. It's good to acknowledge progress that has been made, but it's time to pick up the speed, to go further and faster. We hope that today's conversation is simply a booster dose of energy, that we keep the momentum going through the next Women Deliver conference in Kuala Lumpur next May, because now is the time to deliver for girls and women.
I'm going to invite up somebody else who's been very successful on the front lines, Sweta Mangal of Ziqitza Health Care, and partly to talk about, I hope, the demand side, how you get people to want these services. Sweta.
Thank you, everybody. Namaste. Since I'm from India, I want to namaste. I'm Sweta Mangal. I'm the CEO and co-founder of Ziqitza Health Care, which is an ambulance company. We are a social enterprise, and we were set up in the year 2005 by 5 friends, including myself. I'm educated in the US, so I go long back. My association with the US go long way back. So why did we start this ambulance company in India? And 5 of us, none of us are doctors. We all are management students, 2 of them are lawyers. So why did we come up with this idea of running an ambulance company? Well, it happened by an accident. The accident was that my best friend, who actually was here, his mom choked in her sleep at midnight. And at that point in time, he didn't know what to do. He didn't know which number to call. He didn't know which hospital to go. He didn't know which doctor to call. So he drove his mom in a car to the hospital and managed to save her. But I think that was the turning point. So we as friends, we started to discuss this, and we said, look, if we were in the US, we would have just dialed 911. And in India, what do you do? And as luck would have it, and I think sometimes God gives you signs, a week later, my another friend, her mom collapsed in Manhattan. And the difference was in 4 minutes, a 911 ambulance came and rescued her. She survived. So that was the starting point. So in the year 2004, so this all happened in 2003. In 2004, we thought we'd do charity since we were all very well placed in our careers in Mumbai. And we put in 2 ambulances in Mumbai just to serve people on charity. And soon we realized charity was not the way to go because this service had to be self-sustainable, even though it was very important for the society. So now, after 1 year, we put in our money to run 2 ambulances, but then we said it needs to be self-sustainable. What do we do? So after a lot of discussion, deliberations, we actually came up with a cross-subsidy model. We launched 10 ambulances in the year 2005 under the number 1298, and don't ask me why we got the number 1298. It's a long story. I need a separate conference for that. We launched 10 ambulances under the number 1298 and the cross-subsidy model. So the cross-subsidy model was very simple. Basically, what we did, that we decided that we're going to charge people who go to private hospitals, because in India, people who can afford to pay go to private hospital. And we would give up to 50% subsidy to people who would go to government hospitals, because in India, as you know, the government hospitals are only accessed by the real poor. So the model worked. The model worked and it was successful. So we then wanted to scale it up. We looked for funding. The first investor was Acumen Fund, which needs no introduction. They invested 1.5 million USD in the year 2007. We scaled up to 51 ambulances with that money. However, we were doing pretty well in the urban areas because, as you would imagine, the cross-subsidy model would work in an urban setting where you have a healthy mix of people who can afford to pay and people who cannot afford to pay. But what about the rural India, where 60% of our population still resides? So this question was really bothering us, and luckily, at that same time, the government of India set up NRHM, which is the National Rural Health Mission, to focus on the rural people in India. And under that, one of the scheme was to provide ambulance services to people in India for free. And even better was that the government decided that they will not operate it themselves. That was the biggest decision, because if they decided to run it, it would have been a nightmare. So 2008, and I'm telling you the years because really, I mean, the story really started 7 years back, and I want to come to a point where I tell you what we are doing now. So 2008, the government actually came up with tenders to operate ambulances, and we as a company bid for it. We won 7 out of 11 tenders, and currently we are operating in 5 states across India. We have 860 ambulances operational across 5 states in India. We just won the 6th one, which is Odisha, and that will take the number to 1,200. We have 4,800 people working with us, and ever since we started, we have served 1.7 million people in India, out of which 38% have been pregnant women. So not only that, the most significant fact, which I should actually not be proud of, but I need to state it, we have delivered 5,069 babies on board our ambulances. We are not a maternity care clinic, but you would appreciate that in India we have a lot of challenging situations. Sometimes when we get to the ambulance, get to the lady, she's already at the point where she's delivering, or sometimes when we go to the hospital, there are no nurses, there are no doctors, so we basically deliver on board. So the plan for the future includes expanding in India so that we can continue to provide the services to people in India, but also we are looking at the Middle East market and West Africa to provide the services. Thank you.
Sweta, you mentioned a couple of models where you had the hybrid in Mumbai, and then to get to the rural areas you needed the government, which was also, who wants to go to a government hospital? As you said, I mean, you sort of gave a very mixed impression of the efficiencies of the government in the area of healthcare. And so tell us a little bit about what was it, how have you maintained the same efficiency, or has it been more of a challenge in the rural models, especially as you're trying to expand to other countries? You're now very beholden, I think, to some extent, or beholden's the wrong term, but you're getting a lot of your income now from public money. Does that change the approach in any way? Does it change the pressures that are on you versus being a purely private player? It's a lot, and you have 32 seconds to answer it.
Okay, so does it put pressure on us? I would say no, because we believe that the quality which we have demonstrated while working with the government has appreciated it. More than that, the people of India have appreciated the services. And I can tell you that the government of India is never going to run the service on their own. They are going to engage with private partners because they are so happy with the quality of service which is being delivered. So the quality of service has been our winning strategy actually in India. It's been difficult to work with the government, yes, and that I think it's a story which everybody knows. I don't need to repeat it. There are issues in terms of corruption, there are issues in terms of payments, there are issues, I mean there are a lot of issues. But 5 of us, when we went back to India from US, we said we want to do something for our country and we are going to do it. It's very easy to sit and crib about a country and crib about the politicians and crib about the government and crib about the policies. The best way to do it is you become a part of the system, you work with the system to overcome the challenges, and that's what we are doing.
Is there a cap on your profits? And I'll clap. I mean, there must be, that's one of the challenges I think for private providers is that people don't mind you making money as long as you don't make too much.
Well, that is an issue in India. So this is a contract, right? So there is a tender. So the person who is the lowest bidder actually gets the contract. So profit should not be a bad word. But ironically, and I can say this in this room, the government officials keep saying, even if you're making money, don't show it to us. So I don't understand what that is, but I believe that if the service has to be run professionally, it has to provide quality care, it has to be run by people who are professional, and everything which has quality attached to it comes at a price. So why should profit be a bad word? And I think the bureaucrats, the politicians are understanding that now, and the idea of only NGOs delivering good services is changing. And I'm really happy that today, when we started, we were the only ones. Now, seeing the success of our company, there are other companies who have come up in India, ambulance companies, because obviously one company cannot provide the solution to the entire ambulance industry in India. And the top 3 ambulance companies in the world have set up offices in India, and they have all come because they see government sector as a big opportunity.
Can I just make to another India anecdote which relates to what Sweta was just talking about? So we have a program in India that's involved with maternal health and reproductive health and sanitation and HIV prevention, and we do condom social marketing, for example, in India. About 25% of our funding now comes from the Indian government or from Indian state governments who are contracting with us, an international NGO, on a performance basis to deliver condom social marketing services. So I think this is happening more and more in India.
Thanks. I'm Louise Holly from Save the Children. I just wanted to ask the panel to elaborate on one of the keywords in our title, which is affordable, and how you determine whether the services that you're providing are affordable for the poorest people in particular, because we know that, as the Minister was saying, out-of-pocket payments can make up a huge burden of health financing, and even small fees can deter people from accessing care or worse, push them into poverty. So how do you get that balance right between sustainability and affordability and equity?
Sweta, that would be interesting for you because tell us what the price gradations between if I am pregnant and in need in rural India versus I am going to a private hospital in the center of Mumbai.
We charge you a lot of money. So, affordability is very, very important, and initially when we started the private model, which is the 1298 model, it was based on cross-subsidy. Exactly. You don't need to give affordable services to everybody. you need to give it to the section of society which really needs it, because in developing countries you really need to charge people who can afford to pay and then cross-subsidize the people who cannot afford to pay, and that's exactly what we did when we came up. In fact, I would like to share with you, in the pilot phase, we thought we were going to charge people based on how they look and how they, how do you make out that a person is poor? I mean, you can't. So, and within 3 months we said, no, this model is not going to work, where we are going to judge each and every person based on their outlook as whether we should charge them or not, because the ambulance crew on every bill said the person was poor and could not pay, whereas charge the person. So we had to come up with something which was more objective, and therefore we came up with this private and government hospital and the private hospital model. In the rural India, currently the service is free, so none of the people have to pay for the service, which is very good. But this, I think, is maybe for a couple of years. The government, in fact, a lot of state governments have been talking to us that when women go to private hospitals, maybe we should charge them, and which I think is, a good thought. And people who go to government hospitals, they should be given free.
One of the things about affordability, Nilga, is that to what extent should government be forcing companies like yours or the social franchises to serve those areas, in the same way that if you want to be a carrier in the U.S. going between major markets, you have to serve some of the secondary routes. What's to stop me? I mean, the fear of God goes in you when you hear, oh, and now we have 3 global players that have arrived to try and take your business. What's to stop them from saying, look, Mumbai, New Delhi, great, and we don't have to worry about the rest of the country?
Well, it works a little differently. Actually, the government tells you where you have to operate, and the private companies don't have to give any subsidy to the government. So the government is actually paying you for every ambulance, for every train,
right,
whether you run it in urban or rural areas. But the more number of ambulances will be in rural, because they also understand that that's the population which is being neglected. So for the private company, it does not matter, because the government is paying
at the same profit margin you would get.
Absolutely, it's a tender. So
okay.
Yeah.
Okay.
I would just add to it, I think a cross-subsidy model will work only in urban areas. It will never work in rural areas. And especially in developing countries, if you want to reach the rural areas and serve them, I believe the government is the only way to go.
So, final thank you to all of our panelists.
Okay.